Hello, Dr. Regina Asihene. Welcome to the show. Thank you for being here.
Thank you. It's a pleasure and an honor to be here with you, Pooja. Thank you.
I'm so glad we could connect on this, and I'm thankful to a colleague of mine for recommending you, and I'm glad it worked out. So I know you provided me with an extensive background, and I wanted to give you the opportunity to kind of share with us about your work with the older adult population. I know you're an internal medicine physician, and you've also founded your own assisted living facility. So can you tell me more about your experiences and how they kind of led you to starting your own assisted living facility today?
Sure. I've been a physician since 1992. I graduated from Morehouse School of Medicine, and then I did all my clinical training at Cambridge Hospital, which is part of the Harvard Medical School. So I basically have worked doing internal medicine, which is all adult medicine. Pediatrics is all children. It's often a misconception on what internal medicine is. So with internal medicine, we can take care of anybody from age 13 till the end of life. When they become sexually active is when they officially become an adult. So some are actually younger than 13 when we get them. So basically, I worked with Florida healthcare plans, and I was in the same position for 25 years, same office. So I had the great privilege of seeing my patients age 25 years later.
Wow.
And during that time, some of them got into their 90s and over 100. And I did house calls for those who were not able to come to the office. But as they aged, I realized they needed more help. And oftentimes there's not enough support at home to help them. That's when I made the realization they do need additional support with long-term placement. So, but what really changed for me was when my own father had a stroke.
Mm.
And with 4 kids, all of us working, no one was available really to take care of him full time. That's when I started looking at building my own assisted living facility. I needed a place of extreme excellence to honor my father. So the whole project took me about 3 years. And unfortunately, he did not live to see the completion of the assisted living.
Oh,
But
sorry.
I take it as a way to honor other people's moms and dads.
That's a beautiful story. And I just know if you believe in it, that your dad's looking down on you and so proud and probably so
Thank
glad
you.
that you're
Yeah.
able to pass it on, right?
Yes, thank you.
That's awesome. So before we break down our topic today a little bit, I want to talk about myths because I know you have some fantastic information on this for us. What are the common misconceptions people have when it comes to assisted living facilities versus skilled nursing facilities? Because we know, you and I both know that everybody hears these terms and they become almost interchangeable for the people who don't work in healthcare. And I always try to explain the differences, and it's always a big topic of conversation. So I'd love to hear your take on that.
Yes, there are indeed a lot of myths. A lot of people think assisted living or nursing homes are like prisons. Once you go in, you're locked in and you can never come out. Or they think there's nothing to do. All you do is lie in bed and do nothing all day. Or that I think the most common misconception is that everything's free. The government's going to pay for everything for me. So when I'm old, all my care is 100% free because I have Medicare.
That's the biggest one. The Medicare myth
There
is
you go.
it's insane how much it doesn't cover and how much people don't know that it doesn't cover.
Yes, yes. Nursing homes and assisted living are considered forms of housing, and they're not under the umbrella of healthcare. Medicare will cover the hospitalization, will cover your medications, will cover rehab that's affiliated with your hospitalization. But where you live permanently is not covered by Medicare.
Right.
Yes.
Absolutely. Can you explain the difference between assisted living facilities and skilled nursing facilities when it comes to what type of care they provide?
Yes. Basically, an assisted living is for someone who needs help with some of their activities of daily living, but not all of them. Those who are in a nursing home need complete and total care. So when we talk about activities of daily living, we're looking at things that a person can do for themselves. For example, are you able to bathe yourself, get dressed yourself? Are you able to stand and transfer from seating position to standing position? Are you able to walk independently, or do you need an assistive device? Are you able to feed yourself? So people who need total care need a nursing home. Those who can do some of their activities of daily care can go to assisted living. So assisted living facilities are for those who want personal care, but it's a home-like setting and a more social setting. Whereas a nursing home is more institutionalized and more like a hospital.
Yeah, that's probably the best way I would explain it too. And then there's the nuance of memory care units, right? And you can find those in
Yes,
skilled nursing facilities and you can find them in assisted living facilities. And
that's
that
correct.
also differs, right? So
Yes,
similarly, I think with assisted living memory care units, they're typically able to get up and move around. They just need that memory support or cognitive support. But
yes,
if it's in a skilled nursing facility, they also need all that hands on physical support on top of the memory and cognitive support, right? Um,
that's correct.
and there's just so many levels of care in both of these institutions. I think it's really
Yes,
important that if somebody's considering that move or that option, they really need to sit down with somebody and understand all their options, right?
I agree. I agree.
Um, and so you kind of touched on this already, but what are typical qualifications or criteria for somebody to be qualified for or to enter into living in an assisted living facility versus into a skilled nursing facility?
Right. So, nursing homes are for those who need more medical care in a clinical setting. But assisted living are for those who need personal care in a home like social setting. So, like individuals who've had frequent hospital admissions or multiple medical problems likely need a nursing home. That way, they continue to get more skilled nursing and some limited medical treatments. So, people who need assistance with all their ADLs probably need a nursing home. So, a nursing home is for someone who needs medical professionals for 24 hours. But assisted living facilities for someone who needs more personal care, not medical care, but more personal care. And they can do most of the activities of daily living on their own. So individuals who are still able to function in a home-like setting will prefer assisted living. So those who can walk or ambulatory or they're receptive to assistance.
Right, right. And that comes down to, the actual individual and what their needs are. Now,
Yes,
we always have to take the family into consideration, right? Because it's typically the family that's making these decisions. And
yes.
so, what factors should the families consider when they're kind of deciding between an assisted living or a skilled nursing facility? And do they even have the option to consider those options, or are those kind of going to be decided for them?
They do have the option. One thing about healthcare is that everybody has an option. No one can force you into anything you don't really want to do. So they do have an option. So there are multiple factors that families have to consider. You have to consider the type of medical care your loved one needs. You have to consider what they can do and not do. You have to consider recreational activities. You have to consider the space that's available for them. And then you have to consider the cost. So those are the four main factors you have to consider before you make a decision.
Okay.
Yeah, and the latter, you just mentioned the cost, and how does that cost compare between assisted livings and skilled nursing facilities, what options are available to help them pay for these services? Does insurance cover anything in these facilities when it's not directly for hospitalization related or something, right?
Right.
What are the options there?
Skilled nursing facilities / nursing homes definitely cost more because these are people who need 24-hour care around the clock. They generally run about $10,000 a month. Some places can go up to $12,000, even $15,000 a month. Assisted living facilities, on the other hand, cost a little bit more. A little bit less. So assisted living facilities will range anywhere between $5,000 and about $8,000, depending on the need. Who covers the cost? Assisted living is mostly the individual and their families that cover the cost. But with nursing homes, you have to dwindle down your assets before you can qualify for Medicaid and therefore go into the facility. Yeah, so you lose your personal assets.
Yeah. In your experience, do you find that Medicaid is usually or most likely the primary source of payment?
Yes, especially nursing homes. In assisted livings, it's 50-50. My assisted living, on the other hand, is all private pay.
Sure.
Because we're giving a higher level of care. We have a doctor on site, a nurse on site, and we've added more recreational things and a private chef, for example. So, so I've tried to make mine a little bit unique. Mine is more of a VIP experience for people of high standing in society, if you will. Like my dad was a professor, and so I wanted to honor him with the highest level of personal care.
Sure.
Yes.
And also matching any potential cultural needs, right? I think that's a big area that we're struggling in my community, is that a lot of my community is first generation immigrant parents, and they still very much hold on to the values and the expectations of being how they would like to be taken care of, right? And they're all starting to age now. They're all starting to get older. That generation as a whole, that first generation immigrant generation, is all starting to age now collectively. And we don't have the resources, especially when it comes to assisted living facilities, to meet the cultural needs of these populations, right? Of these communities, whether it's as simple as food, right? You mentioned the private chef, to religion, to religious activities, to cultural activities like holidays, right? To the involvement of family, because that differs culture to culture. Who's making the decisions? Who is the team talking with, right? And so I think that's fantastic. I think privatizing it allows you and others like you to be able to offer more culturally sensitive, culturally informed services in that specific area, right?
Yes, indeed.
So I think that's great. Can you share any insights or advice for family caregivers who might be making that transition now from moving from the home into trying to figure out what long-term care option is their best bet, right?
Yes, first of all, they need to visit and ask questions. So make a list of all your concerns and make sure you're able to ask each institution what they offer. Visit multiple places and ask a lot of questions. That would be the best thing for families that are looking. That way they'll be better informed and know what they're getting into. Yes, and as you said, the cultural things are what is left out of corporate and public institutions. Because they have to attend the needs of masses, everybody gets the same kind of care. Right. But in a private assisted living, we can customize it a little bit. For example, I had one client here, Mona, who was a Jew. And so the rabbi was able to come in and she was able to do services. So we've done different types of religious services. We have Christian, we have Catholic, we've had Jews. We've not had any Muslims yet, but because my institution is new, we've been in existence for only 3 years. But yeah, we're able to customize it. And we also offer, like you said, the food. You can bring in some special food for your loved one if that's something they like. For Easter, one lady wanted a Southern soul food thing, and we were able to provide her the fried chicken, the mac and cheese, collard greens, and the soul food that she wanted for Easter, instead of the
I love that.
traditional turkey or ham or whatever, you know.
Right, because it looks
Yes,
different in every family, right? I
exactly,
mean,
exactly.
Thanksgiving's huge, but culturally it means nothing in our culture,
Yes,
right? And so every year we adopted the American culture of family getting together to have dinner, but not the traditional Thanksgiving meal that you would think about, right? And so
you're
if my
exactly right.
parents were, or my grandma were in a facility where they were doing a Thanksgiving meal, they probably wouldn't even touch it, you know?
No. Yes, I think you know that I'm also a first generation immigrant. My family came to the USA in 1970. My dad came to study to get his PhD at Ohio State University, and he was on a scholarship that allowed him to bring his wife and 2 kids. But he had 4 kids. So 2 of us were left behind, and then
Oh my
we were
gosh.
brought a couple of years later. So I came in 1972. I was 6 years old when I arrived, and this was Columbus, Ohio, which was a complete culture shock in the month of February, going from Africa and then seeing snow for the first time.
Oh my goodness. Where in
Yes,
Africa are you guys from?
I'm from Ghana.
Ghana. Okay.
Ghana,
So it's very
yes. And
warm all the time.
all the time. It's just one season warm. And maybe the months of June and July, we get the rainy season, but that's about
Sure.
it.
Very different from Columbus, Ohio.
Yes, yes. So I agree with you. Thanksgiving was not turkey and ham. We ate our traditional foods.
Right.
Yes.
Right.
And to this
Exactly.
day, we continue to eat our traditional foods, although we may present a ham or turkey. We
Right. Now you've
try to
mixed the two
incorporate a
cultures,
little
right?
bit. Yes, that's correct.
Exactly. Exactly. I think you mentioned a little bit ago when we were talking about assisted living facilities, and you mentioned that sometimes it's 50-50 when it comes to private pay versus outside resources. And
Mhm.
I'm curious what outside resources you've seen from a financial perspective.
Many of my current residents have their own private long term care insurance. It's
Okay.
something that people don't plan, but they should plan. So they start maybe in their 40s or 50s and start putting aside money for long term care. This type of insurance is amazing because it covers everything.
Hmm.
I had one resident named Dorothy. She was 105 years old, but her husband had put the insurance together for her until age 121.
Oh,
So she could afford over 5,000 a month until age 121 because they planned ahead and put together the long-term care insurance. It's probably the best and wisest thing to do is to get long-term care insurance. It
that's
covers you not just for a facility, but if you want to stay in your home, you have the funds to be able to pay someone to come in your home and help you. So that
yeah.
is the best type of um, pre planning you can do for the future. And having learned from the people I work with, I actually have started my own long term care insurance. I'm in my 50s and this is the time to do it. So by the time I reach that age, I also will be prepared and have the funds to be able to do something like this. Yeah.
Right. It's definitely something. So I learned about long-term care insurance maybe 2 years ago now, just
Mm-hmm.
from working in the industry and trying to
Yes.
understand like what are people's options. Because, as already these costs are astronomical, like you mentioned. And if you, especially within our immigrant households, right, like they didn't have 401ks, they didn't have retirement savings. They were trying to support their kids and just kind of survive in a new world. And so they didn't have the ability or the luck or the fortune to be able to
Yes.
invest in their retirement or long-term care. And so just trying to understand what everybody's options are. And I learned that there's, this long-term care insurance that not a lot of people talk about. And I guess it's not a lot of people invest in it either anymore. And just
Yes.
thinking long-term, like our long-term care environment is not built for the amount of people that are going to be aging past 80,
Mhm.
85, 90,
Oh,
right?
yes.
I just read a stat a few weeks ago that when the first baby boomer was born, the life expectancy was 65. And most baby boomers today are living well past 85.
You're
And
exactly
so
right.
they financially and just from a healthcare standpoint, we don't have the resources, right, to
No,
support these
no,
people. And so we really need to think about how that's going to look when we're at that stage. And
exactly.
it's almost unfathomable to think, oh my God, how much is that going to cost?
You're exactly right. They're already saying that Medicare may not exist after a few decades because there are not enough people in the workforce putting into Medicare. Um, After COVID, people went into what's called the Great Resignation, where people didn't want to work anymore. And so a lot of people are not working and a lot of people are not putting money into the Medicare system. So the Medicare system may not exist to the level that it does now. At some point, we won't have a system to support us, which
Right,
means we have to start planning now.
right. Well, and they also, I think they shut down what, like over 800 nursing facilities last year, right?
Yes, yes,
So even from just an infrastructure standpoint,
you
even if
got
we
it.
had the Medicare dollars, we don't have the infrastructure.
You got it. You got it.
So we really do need to think ahead and start
Yes.
planning for it.
And the unfortunate thing is that somehow the skilled nursing facilities, nursing homes have now become the lowest quality of care. Maybe it's government sponsored, maybe the workers don't want to be there, but we've allowed the whole system to really become substandard. And so people don't want to go into these facilities, unfortunately.
Yeah,
And yet some people don't have the option. Mm-hmm.
yeah. Unfortunately, just from working within the rehab industry, I think there's just a lot of layers to why and how the care has become substandard. I think top layers, I think, is just poor treatment of healthcare workers. I think you could attest to
Yes.
that as well.
Yes.
Over the years, the level of respect and the level of pay for healthcare workers has gone down.
It
And
really
so,
has.
the people who are taking care of our society the most are being treated the worst.
That's
And
true.
I think we noticed that during the pandemic, right? We saw that play
Yes.
out,
Yes.
especially when there was the whole healthcare hero thing for the first few months. And then we were still battling it, but the whole world decided that it no longer mattered, right?
Right.
Um, I think another thing I've seen a lot in the Midwest, at least, I'm up in Chicago, and
Mhm.
the consolidation of nursing homes into these bigger conglomerates and this corporate
Yes.
structure. Whereas
Yes.
before there used to be more of these, single owned or private owned or just maybe smaller chains that used to be able to provide more quality care per se. And then they
Yes.
just became bigger, right? And so I think there's a lot of layers to how or why this has become what it has. And I think reimbursement has gone down significantly, right? Or it has stayed
Yes,
stagnant, but the cost of care has gone up. And so as a business, they can't adjust that properly, right?
that's
So if
correct.
cost
Yes,
goes down, if cost goes up, reimbursement goes down, they naturally just can't maintain the quality of care that they maybe once used
yes,
to. And so
yes.
I think there's just so many layers to the downhill battle that our care system is going on right now.
I agree. I do
How
agree.
do you think that has played out in the assisted living side too? Like, do you see any impact on that front?
Yes, I do. Assisted living, okay, let's put it this way. Private assisted living is really for those who prepared for their future and
Right.
they're able to afford it and get the special one-on-one attention that they need. Those who did not plan get the lower quality facilities. And like you said, when corporate takes over these businesses, the quality of care goes down because the workers are treated poorly. The ratio of workers to residents doesn't match properly. So the staff is overworked, underpaid, very discontent, which translates to poor care for the residents. Yeah.
Absolutely. If I may, and you don't have to answer this if you don't want to, but
Mhm.
how do you staff your assisted living? Like, what are your ratios? What kind of, how do you identify what the highest quality care is for your facility?
Okay, so I'm licensed for 16 beds and I have 6 workers for 16 people, which is an overkill. In most corporate places, it's 1 worker for 20 residents. Can you imagine?
I
Can you
didn't know.
imagine?
Oh my gosh.
That's the typical ratio.
Wow.
1 certified nurse assistant for 20 residents. My place is basically 1 worker for 2 residents.
Right.
Yes, so they can get more one-on-one care. The worker
Absolutely.
gets to know the resident very well. The resident shares personal things with them. So they form a bond.
Right.
And that makes it very unique and individualized. Yeah, but the corporate places, it's just a very tough situation.
Yeah. Yeah. And like we said, there's just so many layers to why that's become such a difficult situation,
Yes.
right?
Yep.
Um, okay. So I guess we kind of started talking about this, but what are some, outside of your staffing ratios, which are phenomenal compared to what seems to be the requirement, what are some innovative or unique approaches that your assisted living facility has taken to improve the quality of life for your residents? Are there any specific programs or services that you offer that you might not see necessarily offered in other bigger assisted living facilities? And how do those enhance the well being of your residents to support their individual needs?
Yes, good question. My place is very unique because we have the doctor and nurse directly on site. In fact, it's the biggest paradigm shift that I think all facilities should do. Currently, you don't have to have any medical personnel to run an assisted living facility. The only requirement is to be over age 21. That's the only requirement, which doesn't give the best care because the biggest part of an elderly person's life is their health care.
Right.
That's what they're most concerned about. But that's not a requirement. I want to see a shift where every assisted living facility has a medical doctor and a nurse on site, not by phone, because the phone is just, it could be miscommunication. The nurse can call and just give what she thinks without seeing the overall picture, you
Mm-hmm.
know. So being a medical doctor in my facility, I'm able to directly see what's going on. For example, if there's a fall, I can go immediately, check the vital signs, examine the patient, and having the doctor on site means I can order the x-ray to be brought in. I can order lab work, which is, again, it's a mobile service, and I can order medication in all less than an hour. You no longer need emergency room visits. For
Right.
example, an elderly person with a urinary tract infection does not have to go to the emergency room and sit there for 6 hours waiting to treat a UTI. When you have a doctor and nurse on site, we collect the urine specimen, we dip it, we have results in 5 minutes, call in the antibiotic. The medicine's delivered directly to us. So within 20, 30 minutes, you've diagnosed and treated and saved them an emergency room visit. When it comes to elderly people, it's not just housing. And this is what they've kind of separated. They've made assisted living only housing. But again, I'm trying to change the shift and make it medical and housing. The doctor must be in-house. So when something happens, the doctor can respond immediately without frequent ER visits. In a nursing home, they have to send every patient to the emergency room. Anytime a patient spikes a fever, emergency room, they don't have an option because the doctors are not there on site. But if they were on site, they could do the diagnostic testing right there at the facility and have a diagnosis and treatment. So I think it's something which needs to change with our current system. Our system shouldn't just be housing separate. Then you have to drive back and forth to see a doctor. Yeah, you see where the system is breaking down. The doctor should be in-house with the residents. And I think there are plenty of semi-retired doctors who could do that kind of work, going in every day to see the patients, So that's something unique about my place, is that you can get the diagnosis and treatment in less than an hour without emergency room visit. But mine is not just a medical facility. We actually have a lot of recreational activities for them to do. And in fact, the Council on Aging brings in additional clients just for the activities. Mm-hmm. Mondays, we have bingo. Tuesdays, pets therapy. Wednesdays, live music on the guitar. Thursdays is live music on the piano. Fridays is garden club. Saturdays is art therapy. And Sundays are worship service and Bible studies. So there's always something to do every day of the week. And with the daycare clients, they can eat breakfast and lunch with us and enjoy live music or some kind of activity. And they enjoy coming. They really, really enjoy it. We had one client named Nathaniel, who was a drummer in his youth, but now he was 92 and had Parkinson's disease. We brought him a drum set so that when we have the live music, he can drum along. This gave him so much joy. He looked forward to coming to the daycare every single time the doors open. So it's just a nice little thing to have, So what makes my place unique is that we also bring in people from the community. Those who cannot afford to live here permanently can still come in for the senior daycare activities, and they can also do respite. When the family needs a break and they need to go on vacation or just rest, they can bring them here for a few days. I had one for a total of 3 months who stayed here with us. And again, the Council on Aging, through a grant, can pay for those people who are not able to afford the service. So it's something kind of unique that we do. So we have a lot of activities, and our food, like I said, is very unique because it's cooked fresh every day. We have guest chefs who come in. I think you're of Indian heritage. We did butter chicken one day with with the jasmine rice, which everybody enjoyed. Sometimes we have different ethnic foods just for people to enjoy. So the private chef is a nice, unique touch. Let me see. I think those are the main things that make us a little bit unique compared to everybody else.
Yes, I love that you have the tiered options in a sense, right? You've got the
Yes,
full in-house 16 beds with full
yes,
staffing and activities, but then you've got your daycare, I imagine they can sign up either per day or per week or per month or however
that's
you
correct.
price it
Yeah,
out.
yes.
And then you
You
have
can
the
come once a
respite.
week or you can come every day of the week.
That's
In fact,
awesome.
some of them are begging even for the weekends, but but I think they have a 32-hour thing for the grants.
Gotcha. Okay.
Yes,
I can imagine people wanting to come in every day, but then wanting to go home to their own bed, right?
that's correct. Yes. Some have
um,
pets and different things they need to go home to.
sure, sure.
Yeah.
You touched on a lot of points earlier when you were talking about the importance and the benefit of having a medical doctor on site. So
Yes.
I've worked in acute care for 7 years. I work internal medicine, general medicine. And so my primary area of practice is with these older adults, oftentimes coming in with altered mental status, which is usually due to UTIs or pneumonia, right? Those
You
are the
got it. You got it.
two biggest infections that
Yes.
you often see with confusion in older adults. And then
Yes.
you have the falls, the never ending falls, right? And
Yes.
a lot of times, I did a lot of work around fall prevention and then hospital readmissions and preventing readmissions. And a lot of what I always questioned were our patients who came from assisted living facilities. And I always was curious on why some of these admissions weren't preventable, right? Why
Right.
did somebody who, like you mentioned, if there was a doctor on site, it could have been addressed within maximum of 3 hours from like
Yes.
assessment to testing to getting the medications running. Instead, it became, this entire ordeal of a visit, probably a 911, right?
You
Ambulance from
got
the
it.
assisted living to the
Mhm.
hospital
Yes.
triage, observation. Usually they don't get out of observation, they stay observation. And then they decline because now they've been in bed for 2 days and they're
Thank
confused on
you.
top of it. And now we're from a rehab standpoint, we're kind of struggling between we really don't want this person to have to go to a subacute rehab facility before going back to the assisted living. And we're really trying to get them back to the assisted living with the in-house therapy team or the contracted therapy team. But then by this point, sometimes they're not safe enough because now they've been in bed for 2 or 3 days, but also they don't qualify for subacute rehab because they were under observation status this whole time. And now it's
Exactly.
become this entire ordeal from a patient experience standpoint, patient satisfaction, hospitalization, cost of care, hospital utilization, and
Yes.
some everything that could have essentially been prevented with
That's
having a
correct.
doctor available in the facility who could have addressed all of that on the
Yes.
spot with the
Exactly.
right resources.
We're wasting resources and making the patients decline faster. So,
Absolutely.
yeah, if I have a patient who falls, I can go assess the patient. I can order the imaging study to be done. These are mobile services. So within an hour, they can come and do the x ray. If there's a fracture, I can order the physical therapy and occupational therapy directly on site. Not to mention, I can get the pain medicines and whatever therapy they need directly on site. They don't have to go from place to place to place. So the system that we currently have is not efficient because it's ambulance, it's emergency room, hospitalization, rehab, and many times they never make it back to assisted living. Now it's nursing home.
Yep.
But to
Yeah.
keep the quality of care correct, you stay in one place.
Mm-hmm.
And all of that can be done in a very efficient way that's cost effective and really favors the patient. It puts the patient first. Don't
Absolutely.
take them out of their setting. Keep them in the same setting and give them everything they need right there. They recover faster and they're able to be restored back to their quality of care.
They
Yeah.
do. And I think that's why it's just kind of going off on a tangent, but absolutely, I agree with everything you just said. And I think that's why there's starting to be this conversation around hospital at home, right? Like bringing
Yes.
all of the health services to your home so that you're not getting caught up in this chaotic mess of a hospital care system that we've created. And
Yes.
it's better for the patient, it's better for the family, it's better for recovery, and it's
Yes.
a better use of resources in an
It really
already
is.
very poorly financed healthcare system,
Yes.
right?
Yes. Yes.
Oh,
Yes.
goodness. So we kind of touched on cultural differences, and you kind of already mentioned um, some of the specific services and resources you have for the different cultural needs or religious needs. But I wanted to hear if you've had any firsthand experience regarding cultural differences when it comes to receptivity for assisted living facilities versus skilled nursing facilities. And if so, how have you navigated that?
Yes. Most immigrants grow up in cultures where the family unit takes care of the elderly.
Mm-hmm.
That's the structure in Africa, at least in
Mm-hmm.
Ghana, where I'm from, where that's the model, where the family's responsible for taking care of the elderly. And in my country, we take great pride in doing it. We enjoy
Right.
doing it. So in most developing countries, that's the structure. So getting the cultural people from other countries to understand the change is a little bit tricky sometimes because the model in the US is different.
Mm-hmm.
Um, the young adult is forced to work and therefore doesn't have that option to be home with grandma.
Mm-hmm.
Everybody's working and everybody's become individualized and going from state to state looking for jobs, et cetera, et cetera. So there are less people available to take care of grandma.
Mm-hmm.
And therefore, we have to be able to kind of educate and integrate a little bit of this into the culture too. And so it's difficult for most immigrants to kind of separate the fact that they cannot give grandma the type of care she needs.
Mm-hmm.
Many of them have to quit their jobs and stay home, and then financially becomes too difficult. So I think there's still a lot of education that needs to be done to be able to integrate and let them understand a little bit on how you can get the best of both worlds, in a sense. Um, I use respite as a form to kind of integrate it a little bit. My Latino community has a really hard time letting go of grandma when she needs help.
Mm-hmm.
But if they're able to bring her for a few days on respite, it gives them a rest, and then they see that she actually does okay in a different setting.
Mm-hmm.
Yes. So I think that's the way to integrate it a little bit. Give them only a few days. It doesn't have to be permanent. Just let them try the system for a little while. And then they discover they like it. So I had a few Latino families to do respite with us. Now they love it. Some of them have come more than 6 times within a year because they see the importance of integrating. And their loved one, usually with memory care issues, doesn't even really know where they are. And
Mm-hmm.
it doesn't make a difference. And they make friends, they love the music, they love the food. So somehow they actually have a good time. And it's not as difficult as the family thought it would be.
Well, and it makes
I
a
think
whole
sometimes
world of
it's
a
more for
difference.
the family than it is for grandma.
I'm sorry, say that again?
It is more difficult for the family to let go
Sure.
of that old um, structure than it is for grandma. Grandma usually adjusts very well when she comes into the facility.
Right. And I think that's the thing, right? I think there's this misconception or misperceived understanding, or maybe not, it's not even that. It's really just, like you mentioned, we're collectivist, family oriented cultures. And there's a lot of guilt associated with not being able to take care of
Yes.
your older family member, right? But I think
Yes.
it's that education piece of like, it's better for grandma that way. And
Yes.
it makes a
Yes.
whole world of a difference for the family because
You're
the family
exactly
can
right.
now, one, have the time to mentally and physically rest, and then
Yes.
also mentally and physically be present for their older loved one, older
Yes.
family member,
You're
right?
making a good point.
Yeah, and I always bring it up to, I've obviously had these conversations with my parents multiple times, and it's like I want to remain being your daughter while maintaining the highest level of care for you. If I become that sole caregiver that's doing everything, I'm no
Mhm.
longer going to be your daughter,
There
right?
you go.
You can't
You burn
connect at
out.
that level anymore.
Exactly.
Absolutely. Absolutely.
Yes.
But
And I
these are,
think, yeah, I think that sometimes the loved one taking care of grandma at home doesn't have the educational background to manage, for example, dementia.
right.
Yes, part of our training when my workers come in, they have to do 2 courses on dementia before they can start working. And therefore, they understand the disease and how to manage the disease. And it makes it easier.
Mm-hmm.
One person cannot manage a dementia patient. I know we try to do it on our own, but it actually takes a whole team of people. The burnout rate is so high when it comes to memory care issues. Even among my workers, I only allow 4 days with 3 days off
Right.
because they burn out too.
Mm-hmm.
Yes, but at least they have the education about dementia so they know how to respond when the patients say or do inappropriate things. But
Absolutely.
one person at home trying to do this by themselves is just not possible, especially
Especially,
holding a job and you're
yeah.
sandwiched between different generations. You have your own kids, perhaps your own grandkids, and you have grandma. So it
Mm-hmm.
makes it very, very difficult for one person to do everything.
Absolutely. Yeah. Absolutely. How do you see the future of long term care evolving, and what challenges and opportunities kind of lie ahead?
Well, the first thing is that we need more high quality facilities. And as the baby boomers are aging, we're going to need more support, more medical facilities to support them. Many people are even outliving their children.
Mm-hmm.
Or, for example, my 100-year-olds, their children are in their 80s,
Mm-hmm.
sometimes even sicker than the mother
Mm-hmm.
or the father, you know?
Yeah, I've seen that.
Yes.
Yeah.
So the 80-year-old cannot take care of the 100-year-old. They all have medical issues.
Yeah, I remember
So,
in the hospital sometimes asking some of those older patients in their late 90s or early hundreds and asking them, "Oh, who do you live with? Does somebody help you with something?" And they'll say, "Oh, yeah, I live with my daughter." And like when I was a new grad, I never really thought much about it. But then as I kind of became more and more experienced, I realized I was like, wait, your daughter is probably 80 something years old, right? Like, or
there
70
you
something.
go. Yeah,
Then I started asking, are they healthy? Are they physically healthy, cognitively healthy? Can they take care of you? Can they help you? And just trying to understand that dynamic
right.
because then that affects our discharge recommendations from the hospital, right? If they're
You
telling
got it.
me that they need, if we're saying they need somebody to help them hands on physically, and they're telling us they live with their daughter, well, can the daughter physically assist them because
Usually not.
they're older, right? And that's not, there's some older adults, especially now, who are fantastically healthy, right? Physically,
Yes,
cognitively, they're
yes,
doing very well. And so I always try and get an understanding of, are they capable and do they have the capacity, right?
exactly. Yes. So continuing with your question, um, what's the future of long-term care? We need more high-quality facilities. We're done with substandard facilities. Let's get rid of them. And we have to create things that are of good quality. Number two, we need to make it more modern settings. For example, at my place, they're all private rooms. This day and age of sharing a room is over. Only if it's your spouse or someone, then perhaps you want to be together. But strangers don't need to be intermingling. So at my facility, all of them are private suites. So each person gets their own bathroom and their own private room. And that's the way our facilities need to be moving forward. Even our hospitals are changing. No more of this pulling sheets between residents. Each person needs their own private room. And we need to kind of incorporate technology into our facilities. One thing that we have here are senior iPads, so they can FaceTime with their families. And they do that a lot, by the way. And many of them even send me text messages. So sometimes they're in their room and they'll send me a message, Doc, can you come to room number 10? I'm having a headache. Isn't that funny?
I love that.
Yes, then I'll go there and address whatever issues they have. So we have to incorporate different things that help. For example, we have a special table that helps with dementia. There's some games they can play using technology. So I think that's how we need to be looking for the future. We can't keep the old ways. We have to kind of modernize it because there are other things that we can do that can improve quality of life. One thing we do at our facility, exercise every day. Research has shown that that's what keeps the mind active. That's what keeps the body active. So we incorporate an hour of stretching exercises every day. And those who are able to do the cardio, we do walk around outside. Because we're in Florida, we do get a lot of sunshine. So we try to give them a few minutes outside walking and enjoying the sunshine. So a lot of nursing homes, for example, do not incorporate enough exercise. Or if they have the program, not everybody participates. In our place, we make sure everybody participates to whatever level they're able to do.
Yeah.
Yes.
Well, when you've got a 1-to-20 ratio, you can't really
Yes.
involve everybody, right?
You really
100%.
can.
I agree with
Right.
you. And I feel like that can be an entire conversation on its own about how we start dismantling the current system and creating
Yes.
the future system, right? There's so many things
Yes.
that can be done. And I
Right.
personally, I really think the future is community specific living
Yes.
environments. So if there's, like specifically, I'm seeing an increase in Indian assisted living facilities
Isn't that
specifically or
nice?
communities. Because then
Yes.
there's the socialization aspect, right? We're seeing so much
Yes.
research about the importance of community and socialization to the mental
Yes.
health and cognitive health and the physical health of older adults. And so
Yes.
I think like that's going to also be included in the future of long-term care. And I think
Yes. I'm looking
we need
forward
to
to that.
keep doing that work, you know.
Yes. Now, my nephew, my ex-husband was from Haiti. So my nephew has a home, not a home, but a senior daycare in Massachusetts. And that one is geared only for the Haitian American population. So they speak their natural language there, and the music is of their culture. And so when the residents come in, they feel very at home.
Hmm.
So,
It makes
yes,
a big difference.
it
I
does make a
truly think
big
it makes a
difference.
big difference.
It does indeed.
This was a phenomenal conversation, and I'm so glad and thankful to you for coming on. As we wrap up, what is one takeaway you'd like our audience to consider as it relates to long-term care, assisted living facilities, or skilled nursing facilities?
Okay, so I think at some point as we age, we will all need some assistance. Everyone wants to live to age 100, but your body or your mind will age faster. And at some point, you'll need some help. And when you need help with some of your activities of daily living, assisted living is the right place for you. In assisted living, you have the freedom to come and go as you please and to kind of make your own decisions to much of an extent. If you're closer to the end of life and you need help with all your ADLs, then you need a skilled nursing facility or a nursing home. And that's the major difference between assisted living and a nursing home. But as in this modern day and age, we should now start to improve the quality of care and think outside the box. Everybody's tired of the current system that exists, which is not very good. And it's time to really innovate every aspect of medical care, not just the technology in the hospital and the equipment, but also to apply that technology for senior care.
Absolutely. Well, Dr. Regina Asihene, thank you so much for joining me today and
It's
for
been a
sharing your
pleasure.
thoughts on everything related to long-term care, assisted living, senior care, skilled nursing facilities, just everything in our current landscape and then also the future landscape as well. It's been a pleasure.
Thank you again. Thank you, Pooja. It's been a pleasure here. Have a great night.